So we will go for a new scenario. So this patient is on tamsulosin and finasteride for the past 5 years, but unfortunately now he's presenting with significant difficulty in passing urine and slowness in passing urine, etc. And when you evaluate, you did uroflowmetry, which definitely showed an obstructive pattern with Qmax of only like 6 ml per second. He voided 600 ml with a residual urine of 200 ml. His prostate on examination is large, more than 100 cc. So you did flexible hysteroscopy, which showed a large occlusive bilateral lobes with a large median lobe, and prostate volume is 150 cc. So how are you going to proceed?
So how old is this gentleman?
Is 65.
I'll see this gentleman in the clinic, and I will as he's already had been on tamsulosin and finasteride for the last few years. Therefore, I will now discuss with him a further invasive surgical options. However, I would like to review his history and would know about if he's on any anticoagulants, and would also review his sexual functions, and would like to know his goals and his priorities in terms of saving his or maintaining his sexual functions. I will provide the patient with a patient decision aid. For this gentleman with a large prostate of about 150 cc, he would be eligible for HoLep or more invasive procedures such as the open prostatectomies. But however, my decision would be according to how he is planning, how his goals are, and what he wants to preserve his sexual functions.
Okay. He wants to preserve sexual function, but having said that, he's more bothered about his urinary symptoms. That is his priority. So he's quite happy to sacrifice the sexual function if that is the only way he can proceed further. So the way by which you're explaining, you are more leaning towards the enucleation of the prostate. So what are the various methods by which we can perform prostate enucleation?
The various options include HoLep laser enucleation of the prostate. There's also thulium laser enucleation of the prostate, and then there are the other open surgical options, which can be transvesical or transperineal prostatectomies.
Okay. And explain about holmium laser enucleation, why it is a good choice for somebody with 150 cc prostate.
The holmium laser utilizes the holmium YAG laser, which is a pulse laser, and it helps to enucleate the prostate down to the capsule with maximum enucleation of the adenoma.
Okay.
And as compared to the previous TURP, it has more long-lasting results in terms of very less reoperations percentages, in terms of it being about 0.2 to 0.5% in 10 years, whereas it is for TURP it is about 2% per year, and it has less bleeding, and the patient has a less post-operative stay and early removal of the catheter.
Okay, that's good. And what are all the main side effects of whole beam enucleation?
The side effects of whole beam enucleation include a urine incontinence of 1 to 3%. There's erectile dysfunction of about 3 to 5%. There is retrograde ejaculation similar to what has been seen in TRP, about 70 to 100%. The stricture rate is about 1 to 2%, and the need for going back to theatre for any bleeding is or needing transfusion is 1%.
Okay. You mentioned apart from this whole beam enucleation, there are other methods available like prostatectomy. So what are all the prostatectomy options available for him?
So the other prostatectomy options are open prostatectomies, and can also be laparoscopic prostatectomy or robot-assisted prostatectomies. The open can be a transvesical or a transperineal prostatectomy.
Okay. Is there any other advances in prostatectomy by using the modern techniques?
These are the laparoscopic and on robot-assisted prostatectomies.
Okay, so is there any advantage in doing a laparoscopic or robotic-assisted simple prostatectomy?
It has. I'm not exactly sure.
Okay, so do you know any named prostatectomy procedures?
So there is the Young's prostatectomy and the Millen's prostatectomy. The Young's prostatectomy is a transvesical prostatectomy, and Millen's is a transperineal prostatectomy.
Okay, and so this patient, apart from what we have discussed, is there any other option available for him? 150 cc prostate. We have discussed whole beam enucleation and other enucleation methods, and also simple prostatectomy. Any other options available for him? Any newer methods?
So a relatively less invasive procedure is the prostatic arterial embolization.
Okay, those things like embolization. Okay, embolization is okay, but yeah, go ahead. Is there any other thing other than embolization?
We can utilize. No, I just can't remember.
Okay, so tell me about embolization, how it works.
So the prostatic arterial embolization is basically embolizing the arterial supply to the prostate, which can be done as a day case and under local anesthesia. However, it requires an MDT decision making, in which there are 2 urologists and 2 intervention radiologists. It has lesser impact on sexual function. So after embolization of the artery supply to the prostate, there is ischemic necrosis, and thereby which decreases the volume of the prostate and helps in relieve the symptoms of the patient. This is done in the intervention radiology by the intervention radiologist, and it involves access by the femoral artery, and then accessing internal iliac arteries into the posterior arterial branches. The risks are associated with it is that it is technically demanding. It has a high failure rate. You need to maintain a vascular access to access these vessels. There is involvement of radiation exposure, there may be embolization of the other vessels to the other pelvic organs, such as especially as the penis, and the symptom relief is not immediate, and therefore patient may need to have a catheter in for some time, or and can develop acute urinary retention after the procedure itself, and it does have this post-embolization syndrome, which has nausea, vomiting, fever, and dysuria.
Okay. Is there any evidence to support the prostatic artery embolization?
The prostatic artery embolization, the landmark study is the ROPE study, which was a UK-based study, which showed that prostatic artery embolization non-inferior as compared to TURP.
Okay, that's good. So any other options apart from PAE for this patient?
There's green light laser.
Okay. Green light laser vaporization is more for less than 80 cc or maybe 100 cc, I will say, but definitely not for 150 cc prostate. Any other options for 150 cc prostate?
The other thing is the tulip laser. Is a thulium laser enucleation of the prostate.
Okay, yeah, that's almost similar to holmium laser. It's all anatomical enucleation. We just changed the energy source. What do you know about aquablation?
Aquablation utilizes is an transurethral as well as in the ultrasound guided, image guided, robotic water jet ablation of the prostate, and it requires a pre-assessment of the prostate configuration or mapping, and once those configuration mapping has been done, then the robotic handpiece or arm delivers high velocity stream of water transurethral, and it ablates the prostatic adenoma, and it does not utilize any thermal energy. It usually requires these 2 passes, and then it is followed by a transurethral hemostasis.
Okay. Any studies to support this?
So I'm aware of the Water Trial 1 and Water Trial 2 studies, but I don't remember the numbers as
okay. No worries.
What they are. Yeah.
Good. So your time stops now. So again, a good presentation. The only thing is we need a little bit more smoother flow and more meat to the answer so that it looks much better. So for this patient of 150 cc prostate, I will divide the patient into enucleation procedures, prostatectomy procedure, then minimally invasive procedures like aquablation and prostatic artery embolization. There are only 4 options for anybody with more than 100 cc prostate. And all the enucleation procedures, you can put it in one umbrella, like holmium based or thulium or green light or even bipolar enucleation. And then you can put all the evidences together. We can label it as an anatomical endoscopic enucleation of the prostate. And when you do, try to bring in some EAU 2024 guidelines. Now it's out now, or bring some nice guidelines, bring something so that it's looking good. And say, for example, your value for stricture rate you said is around 1% to 1.5%, but actually for stricture rate for holmium enucleation is 2.6 to 4.4%. So your values are very approximated. Sometimes it's nice to even omit the value if you are not going to be quite closer to the actual value. And you should know a little bit about the open prostatectomy, simple prostatectomies. So Millin's and Freyer's procedures, and how the equivalent of it is used in the laparoscopic or the robotic assisted manner. The Young's prostatectomy is more of transperineal prostatectomy, which is not used that much, but the actual laparoscopic or robotic assisted simple prostatectomy is a mimic of transvesical Freyer's technique. So that is commonly used. Why they use transvesical Freyer's technique compared to transcapsular Millin's technique is it gives more space, and so robotic arms can be easily used in the transvesical manner. So regarding simple prostatectomy, if you are discussing robotic assisted, the best commonly used technique is transvesical Freyer's technique. And other than that, you should know a little bit about Aqablation, and you're good in explaining things, but don't forget Aqablation, because the Water 2 study has clearly proven the evidence of Aqablation for the prostate measuring 80 to 150 cc. That's why I made the scenario 150 cc so that you can discuss the Aqablation. And other than that, people won't spend much time on Aqablation. When you're discussing prostatic artery embolization, you should bring the UK rope study yourself rather than somebody asking you. So overall, today we have comprehensively tried to discuss the complete package of the surgical treatment available. So the scenarios are predominantly like less than 80 cc prostate, more than 80 cc prostate. Anybody with more than 80 cc, especially more than 100 cc prostate, discuss only anatomical endoscopic enucleation of the prostate with various techniques like holmium, green light, thulium, or bipolar. The other options are Aqablation and prostatic artery embolization, and also simple prostatectomy in the form of either open or laparoscopic or robotic. So that's the main thing. So don't miss the main options available. Coming to less than 100 cc prostates, it's only TURP, bipolar predominantly. Monopolar is almost out of fashion, at least in UK. Less than 80 cc, then you are bringing in Urolift, Resume. Less than 60 cc, you are bringing in iTind. So remember like that. So iTind is the most minimalist one, predominantly for bladder neck, as we discussed yesterday. And it's not for very meaty, juicy, lateral low prostates, not for median low, less than 60 cc. Up to 80 cc, you can bring in Urolift, but again, Urolift is only for median lobes less than 1 centimeter intravesical projection. Well, Resume can be done maybe even for 1.5, little bit larger median lobes. Again, the maximum cutoff is 80 cc. So this is the overall preamble. Anybody has any burning questions before we conclude today's session?
Yeah, are there centres that in the UK that are performing iTind?
Yeah, we are performing. We just started now in Birmingham City Hospital. And
Okay.
so, yeah, if I'm correct, I think iTind is done in 4 to 5 centers.
Okay.
Newcastle is a little bit on the leading side. And and we are doing this premise study, which is like a 4-arm, multi-center, multinational study comparing iTind, Urolift, Resume, and TURP. They won't ask much on iTind. If you know a few things like it's a nitinol based one, it creates the Turner-Warwick like 3 incisions at 12 o'clock, 7 o'clock, and 5 o'clock. It can be kept under local anesthesia, and it can be removed under local anesthesia, and it is left for 5 to 7 days, and those 5 to 7 days can cause significant storage symptoms. In fact, in the first presentation, the side effects of Resume, we have used the word like irritative symptoms. So don't use those irritative symptom words, use the words like more of ICS, standardized storage symptoms. Yeah, iTind is very much in practice, but apart from what we discussed in this 1 hour, I don't think they will ask anything more than that.
Okay, thank you.
And yeah, iTind has got various publications like MT1, MT3, MT5. They're all like medical technology, 1 study, 5 study, 3 study, but they're all quite preliminary studies. The premise study may be one of the main study, for I-10, like for example, like lift study, mid lift study, BPH2 study, and pulsar study for Eurolift. Premise study will be the first main study for the I-10. Okay, any other questions? Good.
Thank you.
Good.